Welcome back to the Art of Cerclage. In this video, we will discuss removal of a vaginally placed cerclage. The learning objectives for this video include reviewing when to remove a vaginally placed cerclage, discussing important points and steps of removal, and demonstrating the removal technique on a model. History indicated, physical exam indicated, and ultrasound indicated cerclages are all placed vaginally and during the active pregnancy. They are removed via the vagina at 36 to 37 weeks in the office or earlier if the patient presents in labor. There are a couple of scenarios worth discussing. One is when a patient with a cerclage presents with PPROM, preterm premature rupture of membranes. It's first important to rule out labor in these patients. If the patient is in labor, the cerclage should be removed to avoid damaging the cervix. However, if the patient is not in labor, we have to decide whether or not to keep the cerclage in place. One retrospective study compared retention of the cerclage until onset of delivery versus cerclage removal within 24 hours of presentation of PPROM. The patients who kept the cerclage had longer latency periods, lower rates of IAI, and no increase in neonatal morbidity. There were no differences in neonatal morbidities associated with either removal or retention of the cerclage. Future research needs to be conducted on how best to address this clinical scenario, but at this time, if the patient is not in labor, the decision to remove the cerclage in PPROM is a discussion between the patient and the provider. Another scenario is cesarean delivery. If the patient is having a cesarean delivery, for example for breech presentation, abnormal placentation, history of multiple cesareans, etc., instead of removing the cerclage in the office at 36 to 37 weeks, the cerclage can be removed at the time of the cesarean. Now we will transition to discussion on the steps of removal. It's incredibly important to review the operative report that describes the initial cerclage placement. It's critical to know the position of the knot. Usually this is described as a location on a clock, the suture type and number of sutures used. Merceline is much thicker than Ethibond or Prolene. Additionally, some surgeons place more than one stitch, although this is uncommon. Lastly, it is important to know what method was used for placement. Sometimes, with the anterior and posterior dissection, the Sherrod-Carr cerclage is more difficult to remove. All of this information should be in the operative report, and it's important to know prior to removal. Removal can occur in the office. Proper positioning of the patient and footrests on a GYN exam table and proper lighting is important. Additionally, it is important to have the surgical tools at bedside. You can choose what instruments you'd like to have. You can use a Kelly, long pickup, or ring forceps. You will need long Mayo scissors and a speculum. First, locate the suture. There are two knots. One is the securing knot that helped the cerclage stay in place, and the second is the air knot that assists us with removal. Use an instrument to elevate the air knot. Elevation of the air knot helps you see the V-shaped space above the cervix and under the securing knot. Use the long curved Mayo scissors and insert one blade inside the V shape of the securing knot and one blade on the other side of the suture. Notice how this position does not cut the knot and it only cuts the suture on one side. Cut the suture. Use the elevating instrument on the air knot to gently remove the entire suture. Sometimes you may need countertraction on the cervix to help you pull out the suture. You can use your fingers or a ring forceps. It is very important to inspect the suture and make sure it has been removed in its entirety. If the entire cerclage is removed, then it's safe to labor. Retained suture can cause cervical scarring and possible abnormal dilation of the cervix, necessitating cesarean delivery. Remember, this suture does not dissolve. Rarely, retained suture can lead to infection. If the patient is unable to tolerate the exam in the office, or the cerclage is difficult to remove because of scar tissue or visibility, this procedure can always be conducted in the operating room under spinal anesthesia. Now that we have reviewed the pertinent information about removal, we can demonstrate the steps of removal of a McDonald cerclage on the model. First, identify the suture, securing knot, and the air knot. You can grasp and elevate the air knot with the instrument of your choice, including DeBakey pickups, pickups with teeth, ring forceps, or a long Kelly. With upward traction and some gentle counter traction, we can see the V-shaped space above the cervix and below the securing knot. With the long scissors, we can insert one blade lateral to the suture and one blade inside the V-shaped space under the securing knot. This is a view from another angle. Notice how we do not plan on cutting the securing knot itself, but one of the sides of the suture. After cutting, the securing knot and air knot are all on one side, with the remnant of the stitch on the other side. Gently pull and assist yourself with counter traction on the cervix to remove the cerclage stitch. Inspect the removed suture and make sure you have the entire suture, the securing knot and the air knot. This completes the removal process. Let's review the important points from this video. Vaginally placed cerclage can be removed at 36 to 37 weeks in the office, when a patient presents in labor, or during a scheduled cesarean. More research needs to be conducted if a cerclage should be removed or retained on PPROM patients. It is important to review the operative report to know the location of the knot, suture type and number, and technique. Ensure the entire cerclage is removed. You can always attempt removal in the OR with spinal anesthesia if there's difficulty in the office. This concludes our video series on the art of cerclage. We hope you found these videos helpful. These videos were created and produced by Dr. Sarah Rahman with the mentorship and guidance of Dr. Sarah Signa and support from the George Washington University OBGYN department. This video series is dedicated to Dr. John Larson, an incredible MFM, patient advocate, and mentor to many OBGYNs.